I have not done a video like this in so long, so I know some of you guys are probably screaming. I had talked to one of my subscribers, Sonia Bailey, and I did not realize how, how much you guys actually love these videos. And I don't know how many of my subscribers are OBGYN coders. So I just always feel like I'm constantly giving out the same information when some people may be interested in another specialty. But I'm here to just record my workday, and I'm just going to be reading off some of the notes that I'm getting and the codes I'm using. And yeah, it's just basically a watch and listen to me work, a little typing, a simmer, and all that. So let's go ahead and jump into the video. My son is sleeping right now, so when he wakes up, the video will be over. Hopefully, he sleeps for another 20 to 30 minutes and we have a full video. But let's jump in right now. I'm looking at an office visit. I think I have a whole lot of office visit procedures and prenatal visits that I'm going to be looking at. So that is what you're going to be hearing, and then hopefully we will be able to get into some deliveries and inpatient stuff. But right now I'm trying to get out as much office stuff as possible. So I'm looking at an IUD removal and an insertion. For the removal, we are going to do 58301. That is our CPT code. For the insertion, we're going to do 58300. And for my supply code, which is actually the drug, the IUD that she's getting is Mirena. That is the J7298, and my diagnosis is Z30.433. I already reviewed the documentation, so we're going to move on to our next one. Okay, so for my next patient, she has a commercial insurance, and this is her first prenatal visit. So because it's commercial, we will not bill an E&M for this visit. We're going to bill the 0501F and the 0500F for the prenatal teaching. Some offices may do these visits on 2 different days. My office, they do it all on one day. So I will use the 0500F and the 0501F. I'm getting rid of some diagnosis codes here because they had the Z34 code with O codes, and you could not have those together. There is an excludes one note at the Z34 section in your book, but obviously I already know that because I do this every day. So I'm just fixing some of these diagnosis codes, making sure that they all are for the first trimester. And then I'm gonna make sure the weeks of gestation is correct. And it is. I have to put in her LMP and due date, which she will be due on 10/12. Come on. 2024. All right, and we can move on to the next one. It looks like I have 2 codes that are the same. Okay. All right, next one, I have another IUD insertion and, well, removal, and then they inserted a new one, so her IUD may have expired. So yes, that's what it says. So they used ring forceps to remove it, and then they inserted the new one, and it was another Mirena, so my codes are the same. This patient looks like they also did a urine pregnancy test that came back negative. So I'm going to add Z3202 and link that one to the 81025. And I don't use modifier 51. I can't remember why we no longer put that on there. But if you use modifier 51 on your insertion or on your removal code when you're billing 2 procedures at the same time, that's totally fine. We were just told by management that we no longer need to add it, so I'm not adding it. And this one is good. Next up, I have a prenatal visit and they did an NST. The payer is going to get the O code. So the 0502F, I would not need a modifier 25 because that's not an E&M code. Let me look at this NST. So they did it because she was having cramping and bleeding and it was non-reactive. For that non-reactive, I know it's going to be the 0368330. If she is in her third trimester, I have to check. But the cramping and bleeding, let me see. Okay, so they recommended she go to labor and delivery, so I'm gonna see if she actually went. Okay, she did, and she was admitted by our high risk doctors, so we are not the same tax ID. Even though my providers go to the same hospital, we have different, I forget what it's called, but I don't have to worry about my billing because if she were to go to labor hall and my providers saw her at the hospital, I probably would have to add like a modifier 77 if they did another NST at the hospital, but my providers didn't see her at all, so I'm good to just bill this 59025. But what I will have to do is, because she is my patient, I will have to go in and count her visits that she had because this was her last prenatal visit. She delivered by those providers, so now I have to bill out my antepartum period because we did not do the delivery. So I have to remember to count out those visits. Let's see. I'm gonna put on my LMP, and my primary diagnosis is going to be the antepartum hemorrhage. I don't need this code. And I need weeks of gestation. She was 32 weeks. Oh wow. So my diagnosis are the antepartum hemorrhage, the maternal care for abnormal fetal heart rate, and the weeks of gestation. So I'm going to, why is it yelling at me? Oh, I have to put the weeks of gestation on the 0502F. Okay. So now I have to go and pull up all her prenatal visits. Let's see. Not gonna lie, I get so frustrated when they bill E&Ms when we're supposed to bill global. And then I have to go back and flip them. Whew. Okay, so looks like my office was the only office she went to. What visit was this? I'm gonna have to write these down because they are billing E&Ms out the wazoo. 219, 131. Is this in the hospital? No. What's this one? Another E&M. Another E&M. Okay, I think that's it. So her first preg exam was 9/14/23, and her last one would have been 3/4. So now I need to open up the chart so I can see if we were supposed to build this E&M or if we need the 0502F. So the first one look at is 10/12. Yes, so this should have been routine. Next one. This looks like a routine to me. And my next one. This also looks like a routine. And this last one. Yes. So they all look like routines to me. So now I have to go and do charge corrections. Okay, so the reason for me changing all these E&Ms is because if you don't know, we are going to add up how many visits she had, her prenatal visits, and then we're going to choose between two codes depending on how many she had. And our codes to choose from is 59425 or 59426. Okay. So that's done. Let me refresh. And now let me pull up all my 0502Fs and 05021. She had 1, 2, 3, 4, 5, 6, 7. So that's going to be the 59426. Actually, I probably can just add it on here. Well, no, she had 8. Which is still the same code because I still have one sitting in my work queue from that last visit she had. So let me go ahead and let that one go. And now I'm going to enter the charge for her 59426, which is where that would have been on 219. MRP attached. And then that one is good. I'm gonna go look for it though because I need to put in the dates of service on the comment on the claim. So her first one was 9/14/23. Last one was 3/4/2024. And I will put that my primary diagnosis code is Z3483. Actually, I need a modifier because it's a payer. So this one is good. 8 OD visits, billed, delivery by residency. Okay. Okay, that one is good. So now, off of that one office visit, I had to do all of that. Change all those E&Ms, then count out her visits, then had to bill them out. And now we are back looking at another prenatal visit. And this patient is in her 3rd trimester. Looks like no procedures were done. The payer she has gets the 0502F. And my camera cut off, so I'm not exactly sure where we left off at, but I finished doing the prenatal visits, the antepartum period, I should say, for a patient. She ended up delivering early at 32 weeks by another provider, kind of like if a patient were to go to a different hospital than what my providers than where my providers go to do deliveries. So when stuff happens like that and you have providers with 2 different tax IDs, you can only bill for what you did. We didn't do the delivery, so I could only bill for the antepartum period, which is all her prenatal visits. I counted all of them out and I went with the 59426 because she had 8 visits. And now I'm on to my next patient. Let me see here. This is another prenatal visit that just needs 2 weeks of gestation added. And then I'll be on to my next patient. And let me double check. Yep, no procedures were done. So my next patient looks like needs the weeks of gestation at 32 weeks. And the payer she has will need an E&M. We bill the 99212s for the prenatal visits unless there were complications. There's no issues or concerns today, so 99212 it will be. No procedures were done, so on to the next patient. The payer is a commercial payer, so 0502F for this prenatal visit. And it looks like she's 23 weeks, so we need to make sure the code is for the 2nd trimester supervision of elderly multi-brevida. I had the 3rd trimester. Well, they chose the 3rd trimester, but she's in the 2nd trimester, so I had to change their code to 009.522 instead of 523. And no procedures, so on to my next one. This one's another prenatal visit. They did do an NST. They had modifier 25 on the NST, but you don't need modifier 25 because we're not billing an E&M. This was for decreased fetal movement, and actually it doesn't even look like this is a prenatal visit, so we don't need the 0502F code. I'm just going to use a NOLOS, which is a dummy charge we use when no level of service, like no E&M or no other charge is needed, just the NST. So I'm billing 59025, and I'm going to check the time. The patient was on and off the monitor. The reason was for decreased fetal movement, which is 0368130. The baseline is good, and this was reactive. So I have to attach my LMP, and I don't see the weeks of gestation, so I'm gonna have to use my little tracker here to figure out when or how many weeks she was on this day. So she's due May 22nd, and the date of the NST was the 4th, so she was 28 weeks. And this one is good. All right, now we have an IUD removal. IUD was easily removed in total. Used ring forceps, and the reason was due to severe dysmenorrhea. So my diagnosis codes look good. They have Z30.432, and then they have N94.5. Let me see. Okay, that 94.5 is fine. I'm gonna go with those. Well, looks like they didn't even link that one to that one. They just have the Z30.432 to the 58301. So, regardless, doesn't matter. Reviewed procedure. Now we have a Nexplanon removal. That is the contraceptive that's in the arm. So let's see here. They made the stab incision in the arm and removed. Sorry, I know my verbiage is very minimal, even though there's a whole lot of documentation here. My eyes know where to go for the procedure, so it kind of sounds like, is that all they have in the note? No, that's not all they have in the note. My eyes just go to where they need to go. But yeah, this code is good, 11982, and then our diagnosis code is Z30.46. All right, our next one, we have an NST, and the reason for it was because fetal growth restriction. So 03659, and then probably 30, because they usually do them when they are in their 3rd trimester. So total time 33 minutes. We have the baseline. It was reactive, and now we just need the weeks of gestation. All right, you guys, baby boy is awake. I have to go get him. Thank you all for watching this video. I will see you all in my next one. Bye, guys. All right, he's pretty content. I did want to do like a couple deliveries or surgeries with you guys, not just all office visits. So I guess I can stay on for like 5 more minutes and do that. So let me get rid of this fetal growth restriction NST. And it looks like the patient doesn't have coverage, so we would have to bill an E&M instead of the 0502F. So modifier 25 will go on that E&M. And let me just double check. Yeah, there's no coverage in here. So I think that's it. right, let's go up and look at some outpatient surgeries. So the first one here I have is a laparoscopy for possible fulguration of endometriosis. So patient presents for diagnostic lap with possible fulguration of endometriosis after discussing therapeutic alternatives. Our post-op diagnosis is lower abdominal pain, R1030, and then dysmenorrhea, which is N94-6. So let's look at the documentation and see what we did here. Here are my findings. There are a few clear lesions on the left side of the bladder, reflection in the anterior cul-de-sac. All right, weighted speculum was placed in the vagina. Bladder was drained. After changing the gloves, the infraumbilical area was infused. Veress needle was inserted. The choker sleeve were advanced into the abdomen. Intra-abdominal placement was confirmed. So right now, all they're doing is putting all their ports in, getting ready to start the procedure. They say a 5mm incision was made in the lower quadrant. Further survey of the abdomen revealed findings as noted above. A biopsy device was obtained and used to take a small piece of tissue from the posterior cul-de-sac for further diagnosis. Decision was made not to fulgurate the endometriosis because it was felt to be too diffuse of an area to treat with causing scarring. Or treat without causing scarring, sorry. Scope was removed, the gas was released. So once they removed that scope and they released the gas that they, put in the stomach to help blow it up, the procedure's over. Port was removed and subcutaneous suture was placed to close the left lower quadrant. Steri strips and bandages were placed over the incisions. She's done. Was there an assistant? No assistants here. So all we did was a diagnostic lap and they did take a biopsy. So I'm gonna go over to pathology to see what they have here. Okay, so what they have here is not a diagnosis code, just says fragments of decidualized stroma with focal classification of fragments. So yeah, that's not a diagnosis. So I'm gonna go with the post-op diagnosis codes that were on my note, which was for the lower abdominal pain and the dysmenorrhea. My CPT is it 20 or 21? One of those two. Let me pull up select coder, 49320. And that is for laparoscopy with or without collection specimens by brushing or washing, 493. Okay. Yes, 49321. Yeah, that's what I'm telling them. So 49321. And that one is done. All right, let's do one more outpatient procedure. This is another laparoscopy. Let's see for what. Ultrasound revealed findings of no cause for the pain. Patient now presents for operative laparoscopy. She's having pelvic pain. That is my post-op diagnosis. So let's see what they did here. And a lot of our notes are the same. Like our doctors, they can use a template, and then all they have to do is go in and adjust it to whatever they found or whatever they did. So sometimes the notes are similar. Let's see, the cervix was grasped, abdomen was then approached, the Veress needle was used to inflate the peritoneal cavity, port was placed, examining the pelvis, distal portion of both fallopian tubes was extremely short. There were adhesions between both ends of the fallopian tube and pelvic sidewall remaining tube. Ports were placed. These adhesions were cut, and the adhesion on the left side was fulgurated with cautery due to bleeding. A left paratubal cyst was removed. And examining the ovaries, they appeared normal. The ovarian fossa appeared normal. Cul-de-sac was normal. Appendix was identified and noted to be normal. Again, the procedure, there was no active bleeding. Instruments removed and remaining CO2 gas was expelled. Alrighty, so adhesions being between fallopian tube and pelvic sutures. So it sounds like they did a lot of fulgurating. It says that these adhesions were cut and the adhesions on the left side was fulgurated with cautery, and a left paratubal cyst was removed. So those two things sound like 58662 to me. Let's see, laparoscopy surgical with fulguration or excision of lesions of the ovary, pelvic, visceral, peritoneal surface by any method. So 58662 it is. And again, that diagnosis was for pelvic pain, but let me see what pathology says about this cyst. It says benign tubal cyst, no atypia or malignancy identified. So you can code that, benign tubal cyst. So let's see, cyst, paratubal, which I think is like the N83.8. Let's see. Yep. And yes, N83.8 and R10.2. That one is good.